Hello everyone, so we are going to do chapter 27 in one areas of metabolism, features of environmental metabolism, individually they are collectively numerous. Six are included in the UK National Newborn Blood Sports Screening Program. There is a wide range of presentations. They are unlikely to be diagnosed unless specific investigations are performed. Genetic diagnosis is essential for confirmation and to allow genetic counseling. In some conditions, delay in diagnosis may result in logical damage or death. Families in general involved metabolism and other rare conditions often encounter healthcare professionals with little experience or expertise of their condition. To overcome this problem, the conditions are now often grouped together as specialty rare diseases that affect fewer than 1 in 2,000 of general population. There are over 6,000 more rare diseases. Over 80% of genetic cause in genetic testing, particularly sequencing technology, is allowing increasing identification of these disorders. The formation of specialty of rare disease also allows development and assessment of new treatments and the opportunity to provide patients and families with the specialist care they require. Overview classification in metabolisms represents disorders when enzymatic reaction that decrease in the size of interconvert molecules within cells. There are three broad physiological groups: disorder, intoxication, ready metabolism complex, or canales. This is based on pathophysiology and frequency. They're usually rare. However, collectively, they're not uncommon. Even when familiar hypercholesteremia is excluded, they affect between 1 in 800 and 1 in 225 individuals. Their prevalence varies widely by both country and ethnicity. Fatty acid metabolism disorders are 10 times more common in Saudi Arabia than metabolic disorders, although the prevalence of each are similar worldwide. Pathophysiological disorder leading toxicity due to accumulated metabolized minor cytopathies, homocystinuria, urea cycle disorders, citrullinemia, organic acidemias, isovaleric acidemia, carbohydrate disorder, galactosemia, neurotransmitter disorders, pyridoxine dependent seizures, disorders of energy metabolism, mitochondrial diseases, MLS and MRF, and fatty acid oxidation disorders, carnitine transporter deficiency, and glycogen storage diseases, myocardial disease disorder complex, lysosomal storage disease, and micropolysaccharides, paroxysmal disorders, Leber syndrome, and these are the incidences type of galactosemia is carbohydrate disorder, 1 in 23,000, 1 in 4,500 live births, ornithine carbamylase deficiency, urea cycle disorder is 1 in 14,000, and methyl amylinic acidemia. Organic acidemia, 1 in 50,000, glycogen storage disease type 1, carbohydrate metabolism, 1 in 1 lakh, familial hypercholesteremia, lipid disorder, rare diseases, prevalence less than 1 in 2,000 are increasingly considered as a single entity, although each individual condition affects very few children. When considered together, they're actually quite common as there are over 6,000 of them. Presentation can present in a multitude of ways and at any age. Although many present in early childhood, they should be considered in all children with an unexpectedly severe presentation of an otherwise common illness, significant metabolic acidosis, and unexplained respiratory alkalosis, hypoglycemia, cardiac failure, cardiomyopathy, hepatomegaly, hepatocellular variable liver dysfunction, unexpected drowsiness, trauma or irritability, early onset seizures, dysmorphic features, development regressions that are unexplained, death in the history, specifically ask about the family history of infantile metabolism, throughout family tree, family history of sudden unexplained death, particularly in child epilepsy, learning difficulty, consanguinity, detailing at first, second, or third cousins. Typical profile investigations guided by clinical picture, blood amino acid, acid, thymidines, ammonia, blood pressure screening, test for GAL1 pixel, assay, very long-chain fatty acids, vital enzymes, and lactate. Suspected US cycle organic acidemia or amino acid neuropathic presenting with developmental delay seizures, fraud in growth, suspected URC cycle or cycle disorder of ammonia. And this screening is done for suspected galactosemia, very long-chain suspected paroxysmal disorder, it's a vital enzyme dysmorphism, academically learning difficulties, developmental regressions, like data suspected mitochondrial disease, glycogen storage diseases, and urine organic acid for organic acidemia, fatty acid oxidation disorders, amino acid bilirubin and cystinosis, and glycosamine gas and glycosaccharides from mucopolysaccharidosis and oligosaccaridosis. And genetics are, okay, on examination, there may be not be any specific clinical findings. However, examination including the skin, the musculoskeletal, and ophthalmological system is required. If an abnormal metabolic is suspected, contact a specialist metabolic center for advice at an early stage. Genetics, IEM, are inherited disorders and display specific inheritance patterns. Although mitochondrial and de novo occurrences are seen, the most common mode of inheritance is autosomal recessive with consanguineous percentage of cases of risk. Investigation of metabolic disease is not considered within the differential diagnosis, unlikely to be identified through standard blood urine or cerebrospinal fluid investigation. Early discussion with a specialist center is important. If a diagnosis is clear, then specific diagnostic investigations can be performed with genetic testing. Often the diagnosis is uncertain, as many present with chronic non-specific signs such as developmental delay, faltering growth, dysmorphism, or seizures. Even those presenting acutely with metabolic acidosis or hypoglycemia will need multiple investigation to elucidate the etiology. Investigations are often staged. First investigations are shown in table 27.3. These are often followed by more specialist testing such as muscle, skin, or liver biopsy, genetic analysis, and specific cerebrospinal fluid testing for amino acid neurotransmitters. These should be guided by specialist advice. The management. The two cornerstones of management are day-to-day management of condition with medication and diet, emergency plans for times of high metabolic demand, such as intercurrent illness or metabolic crisis. If a personal emergency management plan is not available, consult an online resource and contact a metabolic medical specialist. The key principles of everyday management are medications, symptomatic therapies, anticonvulsant analgesia, specific therapies, ammonia scavengers, enzyme replacement therapy for limited number of storage diseases, hematopoietic stem cells transplantation is an option. C. Mucopolysaccharidosis MPS type 1 below. Dietary manipulation, there are four potential strategies: supplying a deficient product, regularly supply of glucose and hepatic glycogen storage diseases type 1 by regular daytime feeds and continuous overnight feed. Preventing accumulation of a toxic substrate. In many disorders, there's a protein restriction, phenylalanine restriction, phenylketonuria to reduce harmful metabolites to prevent malnutrition. Protein substitutes and vitamin and mineral supplementation is required, guided by a specialist dietitian. Prevention of catabolism, metabolic demands increased when ill if not met. Catabolism occurs, and certain groups are at risk of metabolic decompensation. Neurocycle disorder patients are at risk of hyperammonemia. When this, patients stop their normal diet and commence their emergency regimen. This consists of an oral glucose polymer polycal, which serves to provide a supply of glucose to meet the body's energy demand and reduce catabolism. It can be given at home, but must be given regularly during the day and night, prompting refusal to drink the emergency drink, the emergency regimen, or deterioration despite taking it requires hospital admission for intravenous glucose, ketogenic diet. Patients with glucose transport 1 deficiency are unable to transport glucose into the central nervous system. Ketogenic diet is used when provide ketones as an alternative energy source for the brain. Children with IEM can decompensate rapidly. They usually have an established personal emergency, medicine plan, nipple wet spot screening, the 3 tests to detect treatable conditions prior to their clinical presentation allows early treatment to improve outcome. Phenylketonuria was the first IEM to be screened in 1960s. Screening has been extended in the UK to include 5 more IEMs, which is offered for all babies on day 5 to 7 of life, with drops of blood from a heel prick collected onto filter paper. The condition tested for cystic fibrosis, congenital hypothyroidism, some hemoglobinopathy, 6 inward error of metabolisms. These are IM detector neuroscreening is phenylketonuria, 1 in 10,000, cardiac frequency 1 in 50, learning difficulty, seizures, and microcephaly. Microcephaly, phenylalanine restricted diet. MCAD, medium chain acyl-CoA dehydrogenase deficiency, 1 in 10,000, nephropathy, often rapidly progressive, collapse after prolonged fast, resulting in ketotic hypoglycemia, and active treat avoidance of fasting and provision with an emergency regimen. A glutaric aciduria type 1, GA1, 1 in 30,000, 1 in 40,000, microcephaly with encephalopathic crisis aged 6 to 18 months, resulting in dystonia, dyskinetic movement disorder, specialized diet, avoiding of fasting and daily carnitine, isovaleric acidemia 1 in 250,000, and metabolic acidosis plus minor hyperammonemia, low protein diet, carnitine, glycine, homocystinuria 1 in 2 lakh, in 1 in 335,000, but more common in those with Irish ancestry in 1 in 65,000. Marfanoid appearance, learning deficiency, lens dislocation, osteoporosis, thromboembolism, low protein diet, and management of low protein. All these were managers' presentations, incidents, and IM. And maple syrup urine disease is 1 in 185,000. Progressive encephalopathy in first week of life, low protein diet. There's a case history, and acid-based disturbances are also given case history of. Wait a second. Okay. We can do case history at the very end. Okay. We'll do case history at the very end. Acid-based disturbances also there, respiratory acidosis. Primary disturbance is increased PCO2 and pH is decreased, PCO-based excess is negative, and compensatory response is increased bicarb. And this is common, this everybody knows, so I guess we can skip it. Or metabolic acidosis is decreased bicarb, metabolic alkalosis is increased bicarb, pH is decreased, metabolic acidosis decreased, PCO2 may be normal or increased, or in alkalosis may be normal or decreased, and then base axis is negative, and in metabolic alkalosis it's positive, and decrease compensatory responses decrease PCO2, and in metabolic alkalosis is compensatory responses, PCO2 is increased. Okay, we'll do it. Identification of MCAD efficiency in newborn screen. Jack was born at term birth with 3.2. On day 5, he had the routine heel prick test for newborn screening. On day 7, it showed he had MCAD efficiency. This was phoned through to the newborn screening nurse who visited the family, checked that Jack was well. She provided them with MCAD deficiency suspected leaflet. Jack was seen within 24 hours with specific metabolic team where blood was for repeat. Testing was given of genetic mutation was taken in the respective organic acid analysis. Consultant explained about the condition and that Jack must not go for more than 6 hours without feed. Specialist dietitian provided an emergency regimen for use at times of illness. The family was advised that any future children would have 1 in 4 risk also having MCAD deficiency. Regarding MCAD deficiency, although screening is important, it can present in the first few days of life before screening with sudden onset of encephalopathy. A few babies die every year prior to screening. Any older sibling should be offered testing if they were born prior to newborn screening or in a country where screening does not occur. Families require genetic counseling. Future pregnancy should be managed prospectively, ensuring at-risk babies receive regular feeds and early biochemical testing. In some countries, a wide range of disorders are tested for as they can be diagnosed by tandem mass spectroscopy. Metabolic disease, acid-base balance is essential to correct cellular functioning. Blood gases may even can help to identify primary disturbances. Enjoying metabolic disorders are compensated acutely by changes in ventilation, chronically by renal responses. Respiratory disturbances are compensated by renal responses only. Metabolic acidosis is common in severely ill children, but may also be presenting feature of an IAM. If raised respiratory rate reflects the compensatory hyperventilation that occurs to promote removal of carbon dioxide, cause small respiration, and IEM is more likely if there is a severe acidosis disproportionate to the usual clinical condition. Abnormalities persist despite standard management. There's a raised anion gap. Anion gap is the difference between the commonly measured cations positively charged sodium potassium minus anions, which are chloride and bicarb in the blood. The anion gap is calculated as our sodium potassium minus chloride and bicarb. Using this equation, a normal value is 10 to 16. This represents the unmeasured ions in blood. An elevated ion gap most commonly occurs when there is lactic or ketotic acidosis, but it can occur in the presence of any unmeasured anion, such as an organic acid, MMA, or propionic acid. Take on case management involves treatment of the underlying etiology and acidosis through administration of soda bicarb. Infection is a common trigger for the presentation of an iron, and both may require concurrent investigation and treatment. Metabolic acidosis and with normal anion gap, intestinal loss of base, diarrhea, renal loss of base is renal tubular acidosis, RTA type 1 and 2 with raised anion or diabetic PKA, renal failure causing salicylate, ethanol, methanol, uh, paraldehyde, inborn errors of metabolism, cases anorganic acidemia. Aisha, a 6-year-old born at term with a birth weight of 3 kg following an uneventful pregnancy delivery presents with reduced feeding and rapid breathing. On examination, his weight is 90 breaths per minute and she's unresponsive to stimulation. Blood test is 7.2, PCO 2 kPa, base axis minus 18. Millimole later bicarb is minus 10, sodium is 140, calcium is 3.6, chloride is 110, lactate is 8, the anion gap is 140 minus 110 is 23.6. Such a large anion gap would not be generated by this level of lactate. The gas normalizes intravenous 10%, the gas normalizes with IV 10% excess, 2 half corrections of soda bicarb, she becomes alert, has a normal respiratory rate in view of encephalopathy and raised anion gap. The urine organic acid analysis of performance shows increased MMA. Diagnosis is later genetically confirmed as MMA acidemia. Always consider environment metabolism, unexplained encephalopathy or markedly raised anion gap. Sudden unexplained death or infancy. And hyperammonemia anemia is a highly toxic chemical derived from bodily nitrogen. It is detoxified urea by the urea cycle, which principally occurs in the liver. An ammonia level should be measured when there is unexplained encephalopathy, respiratory alkalosis because it is a respiratory stimulant, recurrent vomiting, unexplained severe illness in a baby or child, unexplained seizures as it causes cerebral edema. Ammonia can be elevated in severe illness, liver disease by certain medication and transiently in the newborn. Principles of management are to stop feed, start 10% distance, give IV ammonia scavenging medications at arginine to support the urea cycle, and arrange urgent transfer to pediatric intensive care for hemofiltration. Hypoglycemia. Hypoglycemia is common in the first day of life in infants who are preterm. Growth restrictor ill, blood glucose measurements are checked routinely. In these circumstances, thereafter, blood glucose should be checked in any child who seriously ill, has a prolonged seizure, develops an altered state of consciousness. It defines a blood gas of less than 2.6 millimole per liter. Investigation with a hypoglycemia screen at the time of hypoglycemia is required to